Hernias, ladies and gentlemen, this is the second video. This is the more clinically relevant one, so this is more so for clinical practitioners, be it physios, medics, physician associates, nurses, whomever. So on video one, we the first episode on hernias, we deduced what hernias are and what it is we are looking for in a clinical examination. That was more patient oriented for the most part of it. This one a little bit more clinically oriented, and like I say, it's more so for the working professionals. So let's go then. The hernias I'm going to talk to you about today are primarily and predominantly in and around the inguinal region. The first one, as you know, is the inguinal ligament, the inguinal hernias, and there are two types. There is the direct and there is the indirect. Now, the direct hernia is it occurs in the deep inguinal ring, or otherwise also known as the internal inguinal ring. That's and we need to identify the anatomical landmarks on these. And then you've got the indirect, which is in the external inguinal ring or the superficial inguinal ring. These rings are located along the border of the inguinal ligament, and just to remind ourselves, the inguinal ligament runs from the ASIS, the anterior superior iliac spine, all the way across to the pubic tubercle. The inguinal ligament, some references also actually refer to this as being a continuation of the external obliquus muscles rather than a true ligament. Okay, so getting to the actual herniations and hernias, direct and indirect, what we again identify as the anatomical landmark. On the medial aspect, just above the inguinal ligament, the inferior border is the inguinal ligament. The medial border is the lateral aspect of the rectus abdominis muscle, and these two borders with the top form what we call the Hazelback Triangle. The Hazelback Triangle houses, amongst other structures, the res deferens, and I'll explain the significance of that in a short while. Below the inguinal ligament, so the inguinal ligament on this occasion makes the superior border as well as the overlying border of the femoral triangle, the lateral border of which is your sartorius ligament, sartorius muscle, and the medial border of which is the adductor magnus, and then you've got a reinforcement of the adductor magnus known as the lacunar ligament of Gimbernat. The floor of the femoral triangle is formed by what's known as the ligament of Cooper, which essentially is an extension of the pectineus muscle. Okay, so that's your anatomy. Now, the contents of the femoral triangle, you've got the femoral, so going lateral to medial, you've got the femoral nerve, followed by the artery, followed by the vein. Then you've got a little bit of space, and then you've got the lymphatic canal. Inside that, you find the lymph node of Cloquet. The way to remember that is navel going lateral to medial, NAVEL, nerve, artery, vein, empty space, and alpha lymphatic, the lymphatic canal, containing the lymph node of Cloquet. The femoral triangle is located pretty much at midpoint of the actual inguinal ligament, and that's quite an important part to consider. So when we are looking to assess for herniations, again, I reinforce the assessment methods on the first video. Just to reinforce, we place our finger, the pad of our finger, over the point of what we would expect the weakness to be, and you ask the patient to cough. So we essentially are recreating the Valsalva maneuver, increasing intra-abdominal pressure, and through that point of weakening, you'll get the protrusion of any tissue that is, be it mesenteric fat, be it the small intestine, or whatever it may be. Okay. The direct hernia. So the direct inguinal hernia, this occurs, as we said here, on the lateral aspect. So it's the deep or the internal inguinal ring, and what you get is you get a weakening in the transversalis fascia. And that weakening there is what causes the protrusion. The transversalis fascia, the medial aspect of that, is actually joined to what we call the conjoint tendon. The direct hernia is actually a wide neck hernia. It's usually an acquired type of hernia, Acquired meaning that it occurs on the back of strain. So smokers, chronic smokers with a chronic cough, and therefore the repeated intra-abdominal pressure exertion, exerting in the context of weightlifting, for example, powerlifting or deadlifts, exertion in various other ways. So all your exertion or physical exertion and activities that may predispose you to increased intra-abdominal pressure, they are the predisposing factor, the preponderance for direct hernias. Indirect hernia, however, is classified as being a congenital hernia. And so what you get in the given situation here is that the herniation continues down into the inguinal canal, and it exits or otherwise protrudes through what's known as the superficial inguinal ring, or the external inguinal ring. That then actually goes into in males into the scrotal sac or otherwise. Why is it congenital? Well, what you get here is there's actually incomplete closure from an embryological standpoint, incomplete closure of the transverse vaginalis. This also means that usually you'll find in the patient a history of either hydrocele or an undescended testes, or otherwise cryptorchidism. So these are kind of predisposing or otherwise to look out for in the past medical history. To clinically differentiate between direct and indirect hernia, what you've got is the direct hernia. You will be able to feel it, so there's palpation on the cough impulse, whereas indirect hernia you won't. Indirect hernia you will actually feel in the scrotal sac to try and identify if there's a cough impulse. The direct hernia, when you're laying flat, it reduces. The indirect hernia usually doesn't reduce, and now this leads to incarceration, further to strangulation, and then the complications that follow. The difference between incarceration and strangulation, while we're here, is incarceration is the point at which the blood supply to the actual protruding structures, so those structures that are protruding, they are caught, they are trapped. Incarceration is the point at which the blood supply is becoming compromised. Strangulation is the point at which the blood has actually been compromised. So the blood supply has been compromised in strangulation. Now, I mentioned wide neck and narrow neck. So your direct hernia is a wide neck. This basically means that the orifice or the aperture through which the protrusion is occurring, it has a wide neck, and therefore it is less likely to actually undergo incarceration and therefore strangulation, whereas those of them which have a narrow neck or a narrow base, unfortunately, they are the ones that are higher risk. Which takes me on to the other types of hernias. So that's essentially everything you've got to know about that. So what I didn't mention, sorry, my apologies. Inguinal ligament, your ASIS to the pubic tubercle go halfway, and that's your femoral artery. You palpate the pulsating aspect, you palpate the femoral artery as you full well know how to. Then you actually go superiorly about 4 centimeters, so that you're just above the inguinal ligament, and at that point, or otherwise 1 centimeter above the inguinal ligament, in line with the femoral artery, and at that point you will be just over the actual inguinal ring, so the deep inguinal ring, and that's where you're going to palpate. And then you go about 4 centimeters medially towards the pubic tubercle, and that's where you find the location of the superficial inguinal ring or the external inguinal ring. Okay, and not to mention, of course, the external inguinal. So the direct hernia is due to a V-shaped defect in the actual transversalis fascia, whereas the defect in the indirect hernia usually occurs in the external oblique fascia. Okay, that's direct and indirect completed. I mentioned obstruction, and just before I go off the inguinal, more commonly, you'll find inguinal hernias occurring on the right hand side. 60% of cases, 20% of cases will occur on the left hand side, and the remaining 20% of cases may occur bilaterally. A hernia, an inguinal hernia that occurs bilaterally, or otherwise bilateral hernias, are known as Pantalone Hernias. The hernias I mentioned about strangulation, the narrow neck. So these are what we refer to as Rectus hernias or otherwise. Types of Rectus hernias include your femoral hernia, include your indirect inguinal hernia, and include your obturator hernias. These have all got a narrow neck and therefore higher risk of strangulation. I'll hold on to complication for a moment. Your Rectus hernia, by definition, otherwise is a protrusion of the antemesenteric border. So essentially, the knuckle of the small bowel, and that's essentially what gets trapped. In these situations, and so let's look at of the three: the femoral obturator and the obturator femoral, and your indirect inguinal hernia. The most common one is your femoral hernia. Femoral hernias occur in females middle-aged to older age, females more so. And what you get in this situation is you get the protrusion again of the antemesenteric border. And what you'll find is it can occur due to adhesions, preventing the actual the peritoneum or otherwise the viscera to protrude back through the orifice. Or otherwise, you can actually get entrapment of, for example, fecal compaction or a fecal lither or anything of that nature in that protrusion, and therefore it's preventing it actually to be reduced. And again, these were the signs what we're looking for clinically on the previous video, whether it's reducible or not, whether it's painful or not, are there classical signs of infection, and so all of this kind of thing you would be assessing for. But like I say, femoral hernias, females, middle-aged to older ladies predominantly, and it's because of adhesions between the actual protruding viscera, be it the intestine, the mesentery, or whatever, and the actual fascia, or otherwise because there's actual containment of either a fecal lither or compacted feces or whatever it may be. Your obturator hernias. Obturator hernias usually occur in older females who are thin, and the classic presenting complaint here is paresthesias in the medial aspect of the thigh or the inner aspect of the thigh. So remember, paresthesia on the lateral aspect of the thigh, and you're looking at the lateral femoral cutaneous nerve as it passes through those regions again, and that's your meningia paresthetica. In the given situation, we're looking at paresthesia on the inner thigh, the medial aspect of the thigh, and that you may be contemplating an obturator hernia. You then have, so like I said, all three of these, the obturator femoral and the indirect inguinal, are classified as being Rectus hernias. They have a narrow neck and therefore higher rate of complication, higher risk of strangulation. The other hernias you've got are incisional hernias. Incisional hernias usually have a wide base, long neck, and therefore less likely to strangulate. However, they are more likely to reoccur due to surgery or otherwise. Incisional hernias usually occur due to surgery, of course, in the first place. Then you have para-umbilical hernias. So umbilical hernias, we see a lot of this in practice as well. A true umbilical hernia is very rare. For the most part of it, these are para-umbilical hernias, so these can be on the lateral aspect, superior, inferior, and these usually are your periperitoneal fascia rather than actual viscera. Okay. And this usually affects, again, females, and more so females who are multiparous. So they've had a few children, and the more children you had, the greater the risk of that herniation for obvious reasons. Okay. Finally, you've got a couple of other hernias. A gluteal hernia, and a gluteal hernia usually occurs through the greater site of foramen. And then you've got the lumbar hernias, which are extremely rare, and these again usually occur, so you could classify as an incisional because they occur due to surgery and so the surgical incisions. Complications of these hernias, so what you get is you get the incarceration, which I said is a point at which you start to get the compromise of blood flow. That leads to strangulation. Strangulation then leads to necrosis and therefore gangrene. Once your hernia becomes gangrenous, it is then likely to rupture, and if it perforates, then that will lead to peritonitis. Not something we want, a nasty complication. So then we've got to deal with the peritonitis, possibly leading to shock, septic shock. And then you've got quite a bit of a mess on your hands. Differential diagnosis. Just to finish things off, then you've got so if you're thinking a lump in the groin. If it's a fatty substance, then you're thinking lipoma. If it's just in and around the skin or underlying or overlying the skin, then you're looking at a cyst. Remember, an abscess, so how would we know this was an abscess? Well, don't forget, an abscess is essentially an infected cyst, if you want to remember it that way. It's not entirely in that exact same format, but a cyst is a fluid-filled structure, whereas an abscess is also a fluid-filled structure. However, it has also been infected, and therefore there's a massive amount of neutrophil in that one. So abscess or cyst, of course an abscess of course will always give you systemic features of infection. So your fever typically in excess of 38.9 to 39.5 degrees C. And if it's a pulsating lump in the groin, then you're looking at the potential likelihood of a saphenopharynx or otherwise a femoral artery aneurysm. I hope that was helpful. Thank you for watching, and until next time.